the American Heart Association scientific meetings last 2 weeks ago, my team presented evidence that everything starts, frankly, with obesity. And once you start with that particular problem, you will progress into what the American Heart Association now calls the CKM, the cardio-kidney-metabolic syndrome.
You talked about the work that you and I and our colleagues back at Independence that we did in terms of CHF program. Can you break it down what you're exactly predicting? Are we talking about risk scores using social determinants and clinical data within our practice?
Essentially, teams at Independence Blue Cross realized that patients with heart failure were associated with a significant cost. Medicare space were not compensated by the current government reimbursement. And so the question is, how do we manage these patients and why they cost so much? The first question was indeed, how do we find patients who have high rising risk? Because you want to get those patients before they become irreversibly ill and before they are costing you $5,000, $6,000, $7,000, $10,000 per member month. Then we said, okay, if we can identify the major cost drivers, then we can see if we can prevent those events. So once we figure out that patients who had 2, 3, 4 hospitalizations each year met certain clinical and social determinant of health criteria, we then designed an intervention. We could have nurses and we could have field people that could reach out to these patients and say, okay, you are meeting certain red flags, we need to intervene in a different way. So these nurses and at the same time educated the patients about what it means if you gain you ate 3 pretzels yesterday and you gain 1 pound or 2 pounds, you continue in that trajectory. Within today's Monday, Thursday, you're going to be in the hospital.
These are the programs that you, if you're in quality, if you're in risk adjustment, this is the time also to get together with the people who are driving this program from a health plan or in a health system, because this not only impacts cost, but these are also members who are likely also to get readmitted to the hospital. And reducing readmissions is also going to be a star measure, and it's also a star measure on this, Dr. Russo. And I've seen how you've actually, apart from cost, also helped. These are also patients who actually also are happy with the plan eventually when they see an outcome. Welcome to another edition of Healthcare STARcast. I'm your host, Subbu Ramalingam. And today we are diving into one of the most critical intersections in modern healthcare: cardiovascular disease prevention, machine learning, and how we can actually bend the cost curve while improving outcomes globally in the age of AI. This is a special person I always wanted to bring to this podcast. My guest today is my dear friend, a great business partner over the years, Dr. Russo. Dr. Russo, welcome.
Thank you very much, Subbu.
His work in predictive analytics, cardiovascular health, and also in multiple areas in healthcare is helping us reimagine how we identify and prevent chronic disease before it becomes really, very expensive and catastrophic, not only in the US, but globally. He is the chief medical officer of Eversana, and he also wears multiple hats as a global thought leader in this space. What makes the conversation that's going to be particularly important for me personally is cardiovascular disease is also something that I really care about. And Dr. Russo and I have also done work globally in a nonprofit helping many children thanks to his work in terms of pediatric heart surgeries. So it's really going to be a fascinating conversation. So let's dive in. Dr. Russo, we're going to be talking about a number of different things, but I know a lot of background about you. But just for the folks who are new, if you could just give a journey from Italy to the US on becoming a top global thought leader. Give us an intro.
My pleasure, Subbu. Thank you very much for the invitation. Again, my name is Pierantonio Russo. I am the chief medical officer at Eversana, but I started as a cardiac surgeon, practiced cardiac surgery, heart transplantation, and pediatric heart transplantation for more than 20 years, first at the Mayo Clinic, and then as a chief of cardiac surgery in Philadelphia, 2 medical schools, and also at the University of Missouri in the Columbia campus. I came from Italy, and where I was already trained in cardiac surgery, but I really, in the late 80s, I wanted to expand my experience in congenital heart disease and heart transplantation. And this is why I stopped first at the Mayo Clinic, and then again I became the chief of cardiac surgery at St. Christopher Hospital for Children, at the Temple University, the Allegheny University, and many other academic appointments. During those years, I also had the pleasure to work with you and others on developing pediatric cardiological programs in developing countries. Specifically, we focused, you and I, in Chennai, in India, where one of my former trainee had developed a cardiac surgical program, but needed more help in the pediatric component of his program. Between 2007 and 2012, twice a year, I traveled to Chennai, initially even with my entire team, and we helped develop in a good program there. The program is totally independent now, and Dr. Kapadia, who is our friend and colleague, has been able to even introduce ECMO and heart transplantation. After the Mayo Clinic, after the cardiac surgical experience, after 20 years plus, I decided to move to the industry first, where we met at the Independence Blue Cross as a medical director, and then vice president of medical and clinical affairs at Harvard Pilgrim in Boston, where also I was the lecturer in population medicine at the Harvard Medical School. Common thread of that experience, both at Independence Blue Cross and the Harvard system, is the first application of machine learning and predictive analytics to support value-based care, value-based reimbursement, population health. And a common friend of ours at Independence Blue Cross led the data science team. We're talking about 2012, 2013. And we were the first, probably the first health plan, but certainly the first blue plan that introduced social determinant of health as an input in our machine learning models, predictive analytic models, to identify the patients with rising risk, specifically patients with cardiovascular disease, specifically patients with heart failure, which, as you know, cost the healthcare system in this country about $40 billion a year, $20,000 to $25,000 per episodes of hospitalization, beside, of course, the human cost. That experience at the Independence Blue Cross really helped us identify the tools for precision medicine, precision targeting. 20,000 patients with heart failure, but which are the patients that we need to treat in a certain way? We need to manage in a certain way. Some patients will only need perhaps psychological support to improve their adherence. Other patients may need strong cardiovascular specialty care, and others will need just the continuous surveillance of red flags that, if left unchecked, will lead to hospitalization and emergency room visit. We were able to plan significant amount of money, but most importantly, we were able to take care of patients that we selected with predictive analytics in a way that we reduced hospitalization and emergency room visits. Again, that experience was translated in Boston into the first attempt of creating a hospital home, which I had the pleasure to support as well. And now I am working with several data scientists in my current role, where we are using machine learning models and advanced analytic to support, again, precision medicine, precision targeting, and even working in rare diseases, where we are trying to develop tools to support physicians who are not trained in rare diseases in the quick differential diagnosis of patients' phenotype with rare diseases. And the NIH has been supporting it with a full contract.
Yeah, that is a fantastic journey, Dr. Russo. Just pause a little bit. I want to step back and ask you to paint the big picture, right? So you've obviously worked on the global healthcare piece, but let's start with, when we talk about cardiovascular health globally, we're really talking about a crisis that's both medical and economic and social determinants at the same time, right? Sometimes genetic factors. So can you paint a picture of the scale of the challenge that we are facing, right, as global population, and why traditional approaches aren't working right now, right? I know it's a loaded question, but painting the big picture in mind here, right? There are certain places, some things are working, but as global community, it's still as you mentioned, billions and trillions of dollars in terms of impact. So why traditional approaches aren't working?
Well, first of all, let me say that unfortunately, we had been exporting with our Western lifestyle the same problem with cardiovascular disease in places like India. When I first went to my first visit to Chennai or even Hyderabad in India, 2007, the incidence of obesity was minimal. While last time that I was in Hyderabad last year to teach at a postgraduate course to the Apollo system, at the Apollo system, unfortunately, even just landing at the airport, the scene was one of obesity epidemic. So it is really, as you just said, a global problem. And indeed, we just at the American Heart Association scientific meetings last 2 weeks ago, my team presented evidence that everything starts, frankly, with obesity, with overweight, with visceral fat. The patients who at any age develop an increase in the body in body fat, and not necessarily it is BMI anymore, right? As you know, we are now measuring the abdominal circumference because that is a proxy for visceral fat and adiposity inflammation and so on. And once you start with that particular problem, you will progress into what the American Association now calls the CKM, the cardio-kidney-metabolic syndrome. Now, the kidney-metabolic syndrome really framework has taken has been practically well established now. You are starting with this dyslipidemia and adiposity, and then you progress towards subclinical cardiovascular disease, hypertension, diabetes, of course, and then you develop kidney failure. Sometimes the initial stages of kidney failure are not well identified. And so there is a progression even for patients who have other risk factors like hypertension and diabetes towards late stages of CKD or chronic kidney failure. And in between, you have the interplay of arrhythmias. Kidney failure, it is an accelerator of arrhythmia, but also vice versa. The arrhythmia can accelerate heart failure and kidney failure. All of that is now being studied by various organizations in this country and abroad, and it's been sponsored, and these studies are sponsored and encouraged by the American Heart Association, exactly because now we understand that there is an interplay between all these organs, right? It's not just cardiology, but it's nephrologist, it is endocrinologist, all working together. And we also know that we have drugs now that can somehow mitigate, particularly if started early on, the progression of cardiac-kidney-metabolic syndrome. Think of the GLP-1 agonist and think of the SLG2 antagonist. These drugs are now being identified as potentially taking care of the metabolic problem as well as the organ problems. And of course, hypertension, as you know, is also another huge problem in this country, in the West, responsible by itself for probably more death directly and indirectly than myocardial infarction, and being responsible for at least $100 to $150 billion in direct and indirect expenses. So, but the advantage is that finally we know that all these diseases are now a syndrome. It's not just one disease, and we also know how to treat them.
Yeah. So, Dr. Russo, let's bring this to life for some folks, right? So we have folks who work in a health plan who are actually managing larger population who are listeners of this. We have folks who are running a physician practice, ACO, etc. Right. So if I am a physician practice, right, so a few thousand lives, a few hundred lives, so let's say I'm managing, let's say a few thousand, right? Um, so predictive analytics, it's buzzword used for a number of years. Obviously, machine learning, in a component of it. And you talked about the work that you and I and our colleagues back at Independence that we did in terms of CHF program that was actually super impactful, which we'll jump to it a little bit later. Can you break it down what you're exactly predicting, right? So, few thousand lives, what are the different approaches that you would use? Are we talking about risk scores using um, like social determinants and clinical data within our practice? And then how does a doctor and the care team work together in this framework?
Well, let's start with that experience that you and I have shared, and we can tell the story. I mean, essentially, the teams at the Independence Blue Cross realized that that heart failure, patients with heart failure, were associated with a significant cost, which of course was not particularly in a Medicare space, were not compensated by the current government reimbursement. And so the question is, how do we manage these patients and why they cost so much? Can we improve their outcome, but at the same time can do it in an efficient way so that we can reduce cost? And the question that was posed to me actually by the chief medical officer, and the first question was indeed, how do we find patients who have rising risk? Because you want to get those patients before they become irreversibly ill and before they are costing you $5, $6, $7, $10,000 per member a month. And the idea was to put together a number of input into a machine learning model, in predictive model, that were both clinical, therapy, pharmacy, but also social determinants of health. And where is the patient residence in relation to the major hospital or a clinic? Are there transportation issues? Is the patient depressed? Because if the patient is severely depressed, will not be adherent, right? There is no reason to discuss with the patient diuretics and the beta blockers if the patient is depressed and has no motivation to improve. And so the motivational interview became an issue that we started to discuss. But then we said, okay, if we can identify the major cost drivers, then we can measure those cost drivers, and then we can see if we can prevent those events. And of course, emergency room visits and hospitalizations are the usual suspects, are the cost drivers, the top cost drivers. Particularly in heart failure, it's not the medication, it is the hospitalization, the emergency room visit. So, next question, how many patients experience today 2, 3, 4 hospitalization in a year? And what is the pattern of those patients? Because then, as you know, machine learning essentially look at previous patterns and try to reproduce those, try to learn from those patterns and apply those patterns to patients who, in this case, patients who have not experienced those trajectory yet. So once we figure out that patients who had 2, 3, 4 hospitalization each year met certain clinical and social determinant of health criteria, we then designed an intervention. The intervention at the time was conducted by partners that we hired externally, but most importantly, we put together protocols of care that were embraced by more than 400 cardiologists in town, in various groups, various hospital groups. And that was very important because then we could have nurses and we could have field people that could reach out to these patients and say, okay, you are meeting certain red flags. We need to intervene in a different way. The other component, it was one of the first in the country, was to use remote patient monitoring with various devices. Mostly we monitor blood pressure, heart rate, and the weight and pulse oximeter in those selected patients who were, we called riser risk. So patients who today they are not costing me $3,000 per member per month, but 6 months from now they may, because they end up in a hospital two or three times that in the next 6 months. So these nurses, the call center was monitoring these parameters remotely, and at the same time educated the patients about what it means if you gain you ate 3 pretzels yesterday and you gain 1 pound or 2 pounds, you continue in that trajectory. Within today's Monday, Thursday, you're going to be in the hospital with pulmonary edema, with swollen legs. And so not only there was this component of external monitoring, but also and remote monitoring, but also the patient learned how to essentially manage themselves. They started to understand what was happening.
Huge, man.
Yeah, what was happening when they deviated with their diet, with their fluids, with their salt, and so on. And so we had nearly 2,000 patients monitored. I still had the map in my archives of all the patients, of the dots in the map of the city of Philadelphia, where we had the patient monitor with this remote patient monitoring. And at the time was an investment on the part of IBC, because we did not have a way to get reimbursed by Medicare. Today, there is indeed that opportunity. But having the cardiologist also helping with a standard protocol that was essentially driven by the American Heart Association and the various recommended therapies was extremely important. And so every patient under care followed a protocol based on real-world evidence.
It's awesome way you brought to life in the project that we did, and it's still relevant, right? Even if like there are really maturity of machine learning models, still that multifacets, multidisciplinary team, along with the data is important. But here's something that I wrestle with, Dr. Russo. As a non-clinician, right? So machine learning models are getting incredibly accurate, right? So we see more and more evidence of that. And sometimes they're often seen as black boxes by some clinicians, right? They don't always trust why the model is flagging a particular patient as high risk. So quick thoughts, from you on what are the best practices? How do you bridge that gap between algorithmic accuracy and a clinical trust, right? Because it's the care team who's actually managing the population. So what are couple of things, in your experience that you would do with the clinicians?
Yeah. So actually, we are already working with clients both in pharma and clinical, and for quite a while. And of course, the Independence Blue Cross, we reached out to the cardiologist to explain why their patients were a rising risk. We call them the risers, right? And as you know, machine learning is one of the component of artificial intelligence. So generative AI is another one. And of course, LLMs that now allow essentially to the machine to reason is another one. But machine learning is it is an extension. It is, in a way, we need to think of machine learning as an extension of statistics, but it's just used to use multiple inputs, 100, 200, 300 inputs, which of course is not possible with traditional statistics, and from multiple data sources. Again, it can be social determinants of health, can be demographic, can be ethnicity, can be the patient journey, the experience of the physician, the location of the hospital, the standards of the standard of care of that hospital, right? So all this, because of the computer power, now we can put all together in this these predictive models that essentially are using regression models, but they are, instead of statistics, is through these machine learning models that are acquiring a lot of this of this input. But there is also if done correctly, it is essentially you don't allow the machine to do an unsupervised learning. It is always supervised. In medicine, you may start with a supervised learning. So essentially, you don't program the machine, and machine spit out what the trends are and the connections are, right? But I would say that the most successful clinical machine learning models are those in which a human, an expert, like a clinician, helps with feature extractions. So after the unsupervised learning, you actually identify, this was the way we do it, we identify what makes sense to a nurse, what makes sense to a physician, what makes sense to a health insurer, a payer, what counts. So that feature extraction then is still introduced in a model that then compare the target cohort with a control cohort. So in a way, there is an experiment as well, an experimental component, because there is always, at least the way we do it, there is always a control group, right?
Yeah.
And that control group can be even 3 times the size to really make sure that whatever features are in between the two is certainly evident in the control group, potentially, if it's there, if those features are shared. So I think that the key, you're absolutely right, that physicians, particularly older physicians who are not trained in machine learning and not trained in AI, digital, may be suspicious. But the way you approach that is to actually show exactly like we used to do with statistics. This is what we put in. This is what the model shows. Now, doctor, if you feel that we missed any input, we can actually retrain the model. So one of the advantages of machine learning models is AI models is that they learn by including new information all the time. And now the AI agents that essentially work with you as your resident in a way, or your assistant in a live way, essentially they are live, they continue to learn by receiving new input. So the way we are doing it is exactly that. We are going to our partners for which we work, and we explain what was entered in the model, so there is no black box, and what the model looks like mathematically, and we actually show the positive predictive value, the statistical matrix, true positive, true negative, false positive, false negative, so sensitivity, specificity. So in a way, if somebody is trained in statistics, they will understand it. It's just that it's done in a more efficient way and with a large number of data.
Yeah. And you hit it, transparency, and also with the new technology, you can train better with inputs. Isn't that awesome? Right? Remember 10 years ago, it was, to train it took a longer time. Now you can, as you mentioned, you could train it really faster.
Right.
So when you train it faster and you show the outputs based on the inputs, you get it fast.
Yeah, and most importantly, because of the positive predictive value that you can identify from your model, right? You can then calculate the number needed to treat or number needed to monitor. And that is very important for the payer, because if I need to invest in a certain intervention, I want to know how many patients I need to indeed include in my intervention in order to get a significant yield that then translates in a cost saving, as well as, of course, in improving the outcome of a good number of patients. So, for example, we put together a model for a client that was interested in identify how many patients do I need to provide with a ambulatory EEG monitor in order to diagnose, to identify silent atrial fibrillation, which silent atrial fibrillation is a huge problem, because nearly 30% of patients with atrial fibrillation end up being silent. And what happens is that they are diagnosed in the hospital with the complication of atrial fibrillation. So they show up with stroke, they show up with heart failure, they show up with perhaps ischemic guts. And so all of that not only is in human cost, but also it is $20,000, $25,000, $30,000 per episode. If you get a stroke, it may cost you $1 million to the healthcare system. So, but the question is, if I need to spend an additional $300 to monitor patients who I don't know if they have atrial fibrillation or not, what is the yield? What is the diagnostic yield, and how many do I need to test in order to get at least half of it being positive? And the predictive model that we built on claims is now being validated actually in electronic medical records, and shows that if you are a certain patient with certain diabetic profile, you may have such a high risk of developing atrial fibrillation at some point that nearly 6 months before you develop atrial fibrillation, I can monitor you. I can monitor 5, and 2.5 will have indeed atrial fibrillation.
Yeah.
So I save so I invest $300 per patient, so $1,500 for 5 patients, but I may save indeed $60,000 in hospitalization on 2 patients.
Yeah.
So that is a good return on the investment, plus saving patient complications.
Yeah. And Dr. Russo, one of the things from a U.S. healthcare perspective, right? So we talk a lot about stars, quality, risk adjustment, obviously cost, in this podcast, but specifically these kind of programs targeting from a cost perspective, for the viewers, these are the programs that you, if you're in quality, if you're in risk adjustment, this is a time also to get together with the people who are driving this program from a health plan or in a health system, because this not only impacts cost, but these are also members who are likely also to get readmitted to the hospital. And reducing readmissions is also going to be a star measure, and it's also a star measure. These are programs that also improves medication adherence at an appropriate time. So these are going to improve the star measures there as well. Because I know you and I had collaborated on this, Dr. Russo, and I've seen how you've actually, apart from cost, also helped. These are also patients who actually also are happy with the plan eventually when they see an outcome.
Right. Now, and again, I think that it is time for health plans and for CMS to move more aggressively towards measuring outcomes rather than just process, because for a long time we have been measuring again process, but without taking in consideration whether that process led to better outcomes. Today, we have a large number of data. We have the computer power, and we have the mathematical algorithms that will allow us to connect the selection of the metrics that we are measuring with outcomes, and eliminate those that are inconsistent with significant outcome improvement, and only limit to those that indeed are associated with outcome. At the same time, what is the cost of quality? You probably remember that I think it was 2011, 2012, that I was first author on a paper that essentially from IBC. I mean, we use the experience at IBC, but also other knowledge that showed that there is a cost associated with quality, and that we need to select that process, that treatment, that management that improve quality, but at the lowest possible cost. Because if you experience a very large cost in improving quality, whether it is in healthcare or in the industry, that becomes unsustainable. But in general, the most effective treatment for the patient reduce cost.
Yeah, totally.
Right? And most importantly, the low value care that we continue to experience in our healthcare system is based on the inappropriate selection of medications or general treatment, inappropriate targeting. So the patient is not receiving, the specific patient with heart failure may receive a treatment that it is there to one size fits all diuretics or beta blockers. In fact, the patient may need mineral corticoid antagonists, for example, right? Because of hypertension, because of kidney failure, and so on. So we need to introduce the concept of precision targeting and precision medicine in our star rating, in our quality rating. And
Absolutely.
then the payer may need to educate the physician on the ground with our physician networks, right, management, to let them understand that today the formula is the right patient, the right drugs, right treatment, right location of service. Hospital is not necessarily always the right location of service. In fact, many cases for chronic condition is not the right place. Let's treat them at home. And we have ways to keep them at home. And if we need to provide assistance at home, we will.
Yeah, and that drives the cost, to your point, right? So, so cardiovascular disease, I mean, last year's report, right? Dr. Russo, over 200 billion.
Yes.
In terms of impact in U.S. healthcare. Just the previous podcast episode, I did like a macroeconomic impact of U.S. healthcare and economy, about $4 trillion and rising,
Yes.
right? It's a big, significant piece of the pie on that one. So some of these that we talked about, definitely it's a huge ROI in the U.S. healthcare system model.
Yes.
Right. So whether it's fee for service or whether it's value based, it makes sense, right? Huge ROI with the rising trend of chronic disease makes complete sense. Lots of opportunities here. So you work also in teaching and also work in global healthcare. Let's take some developing countries, right? So let's say India as an example, where you also teach and work. So give us a perspective, right? Because the cost and the incentive systems are very different there, right? What are you seeing in terms of this, not only the skills, but also implementing some of this in a customized way in a US, in an Indian healthcare system?
So actually, I wrote a chapter on a book that was sponsored by Wharton School of Business on the advantages of the private sector approach to healthcare in India. And that, and to make it as simple as possible for people to understand, the private sector, like let's say Apollo, Fortis, right, hospitals, is based on the interplay of three skills. One is engineering, the other one is hospitality, and the other one, of course, is physicians. But these three domains work together. Engineering essentially work on all the process of how the hospital function and what is the most cost-effective way of using certain equipment, right? The hospitality, of course, is the way we are treating patients when they come in, and they actually the many of the managers of the hospital are coming from from hotels, from yeah. And then, of course, the physicians. And in the private sectors, the physicians, particularly in large hospitals, are all people trained in abroad, and then in India, and then abroad, and then back to India. So they have the advantage of the Western training as well as the experience of large volume in India. And the secret there is that we obviously treat the patient as a customer, right? As a client, not as a patient. Again, I'm talking about the private sector. And then we make sure that everybody has the same basic medical treatment. But if someone can afford amenities like a special television size, they pay additional money and they get that. They want a bigger room, they pay more money and they get that. But the basic medical training by the physicians allow you to say that the standard of care is the same, right? And then there is efficient use of the resources. Example, there are situations where in this country we have X-rays machines for the morning, and then that are not used at night, and then the machines for night they're only used at night. It's my experience, and again I reported even in the chapter, is that in certain hospitals, private hospital in India, the same machine is used in the morning for the emergencies and for the round, and then is used in the afternoon for the outpatient. Same machine, right? There are certain advantages of combining the structured approach of an engineering domain with, of course, hospitality training, as well as, of course, a physician who have high quality training abroad, and then they have the experience of the high volume in India. In the end, I was last year. I taught on behalf of the India School of Business for executive of the Apollo healthcare system. In the end, the message was, look, we are going to offer what the patient client wants, when the clients wants, in the location where they want it, at a price that they can afford, that they are willing to pay. And that's value, right? That is the value. Now, here, unfortunately, in this country, as you know, we have been sort of isolated from the cost of being taken care of, right? So if I go to the hospital, I mean, I know, and you know, but many people don't know how much it costs. Well, they may see the bill, but doesn't mean anything because it is the insurance company that pays and so on. And most importantly, I see continuously now that I have access to national databases of claims, 300 million lives I have in the house. I can see this continuous swirling of low-value care patients who are not getting better, but they are still kept in the same medication or the same class of medications,
Yeah.
right?
Yeah.
And so what it means is that you're spending an enormous amount of money on low-value care because those patients end up in the hospital, they end up in the emergency room where you wait several hours and then you are treated by maybe junior staff and so on. So now my experience in Boston was a little different because at least for my health plan, of which I was responsible, nearly 70% of my contract with providers were value-based care.
That's huge. That's huge.
Okay,
Yeah.
so that it is your money. I give you $500 per member per month. You do what you want with it. If you, in the end, you are unable to show me that your risk is higher than what I predicted, I'm not going to give you a single penny. In fact, if it's lower, you need to give me money back. Right? And this is a combination of electronic medical records and risk adjustment, both, not just risk adjustment. And so they know that in the end, it's their own money, it's the doctor's money. And so they are using that capitated dollars, much more savvy way than if we do it fee for service.
It brings down the execution at that point. Really.
Exactly.
Yeah. So a couple of quick questions before we wrap up, right? One is more personal, and the other is a little bit more futuristic, right? Let's start with the personal one. So I know, Dr. Russo, you had mentioned to me in several conversations in a one-on-one about the like the tours that you had in Chennai, right?
Yes.
So I still get like letters, right? You get letters, I get them because we're part of the same organization, Gift of Life. So what is probably one of the most satisfying case that you did in terms of pediatric heart surgery in Chennai? If you could share one anecdote, that'll be fantastic.
Yeah. So obviously, maybe another time I can go over some of the pictures that I have of the children that returned to see me after the first visit. All these children were operated on for congenital heart disease. They were born with holes in the heart or malformation of the heart. And it was quite interesting to see how the families, even the poor families, wanted the children to look very elegant, and sometimes they had the most beautiful dress or suit, a little suit for the boys, but they didn't have shoes because they had to choose between shoes and suits or dresses and clothes. And of course, Gift of Life intervened immediately in those situations to provide the children that they needed, what they needed.
Yeah.
Most of the, I would say that the procedures, the complex procedures, the procedures of the patients who really would have died without the operation, would have died probably in a year or two, like single ventricle physiology, only one pumping chambers, the special valve procedures, they were all very satisfying. But I think the entire experience was satisfying because we saw continuous progress, and we saw that the local community really wanted to have the hospital to reach those standards, which are Western standards, and they did. In the very few years, they did. So I don't think that there is a problem in those hospitals. Again, they unfortunately are all private hospitals. The public hospitals is something that eventually the Indian government need to try to address. But poor children were operated in those private hospitals because of the partnership between your organization and the hospital. So the hospital said, okay, we are going to have 3 or 4 children being operated for free, and you guys take care of the rest. So beautiful partnership between the community, the private sector, and very dedicated physicians. So I'm very bullish about India, as you know, because I've seen a country that continues to improve with education and hard work. And I have at least, I think, 10 data scientists in India right now working with my team here
Your team, yeah.
in the States.
Dr. Russo, we're so grateful for the work that you do, not only on behalf of the organization Gift of Life, but also on behalf of Chennai, where I'm from. I'll tell you a quick story. I think I mentioned to you one time I went a few years ago. Was in Sheraton, and there was one of the guys who actually takes care of parking, and he's like the security guard. And then I was talking to him about something, and I was like, "What are you here for?" And then I was like, "Yeah, I'm from Chennai. And I'm here for one of the projects, Gift of Life." And his face lit up, right? And he was like, "Do you know Dr. Russo?" And I least expected it, right? So it's like completely. He's not a doctor. He's not like he was lit up. He was like, say thank you to him, and so it goes to show how intimately that you worked in the community there and made an impact, not only with the work you did, but the way you presented yourself as a human being. So with that said, another personal question, Dr. Russo, this is probably a takeaway for people. So I've known you for 15 years, but you still look the same, and I'm probably aged. So what are some personal secrets that you can give some people some insights on your secret for your youthfulness?
Well, first of all, I was born in Italy, and I think that some of the areas in Italy, like my parents were from Sicily, like Sardinia, Sicily, they really are blue zone in that they somehow there is longevity. For example, my grandfather died at 113 years. And he was an accountant, and he worked until about 80. My father died at 89. Suddenly, he developed gastric cancer, but until 6 months before that, he was working full time as a lawyer and a consultant. So there is no question that genetics is important. The second thing, though, I believe, is that working if you like what you're doing and you continue to work, that keeps your mind very young. I was lucky in my career that I was always had the opportunity to be involved in innovation. For example, when I came to Philadelphia, the innovation was neonatal heart transplant. Nobody had done a neonatal heart transplant successful. They had tried, but they had not been successful. I was at the right time, at the right place, at the right time with the right team. And we did the first neonatal heart transplant in 1992 successful. Then in 1994, we did a 3.5 days old child. And I believe that only transplant. And the young lady now works for the American Heart Association. And that innovation, that was the innovation. Then when I joined Independence Blue Cross, was the first time that we used data science and machine learning for supporting population health. Now with AI. So I think that being an innovator, being involved in innovation sometimes is lack, but keeps your mind sharp. And of course, Mediterranean diet. I really cannot say more than Mediterranean diet. In Chennai, I started to learn more how to use to eat vegetables and so on. But even before going to India, I never ate too much red meat, very rare, very selective fish, and the rest is Mediterranean diet, very strict Mediterranean diet, and of course some physical activity. But I think the key of doing what you like and continue to work until you can physically do it. It is a secret that many people with longevity, we'll share with you.
Fantastic. Dr. Russo, with that, we'll wrap. Those are some really sage advice and wise advice. And also, thank you for going through all the evolution of the prevention machine learning. I'm sure there are more things that we can talk about, future of medicine, etc., definitely in the future. But I think we'll come to a logical close to the podcast with this time. So really appreciate you being part of this. Any closing thoughts from you?
No, I think that if we have an opportunity in the future, one of my master class last year, 2 years ago, at one of the international conference was the hospital of the future. The hospital of the future being not a physical hospital, but in fact a hub that connects the physical hospital, the clinic, the home, the consultant, and fidelity knowledge, all connected in a digital way and supported by AI. And of course the use of robots and the use of connection, digital connection, and education and engagement of the patients with digital solutions that are available today. So if at any time you want to discuss that, I'll be happy to share that.
Yeah, that'll be fantastic. That's where the future seems to go, right, in a very rapid way. Thank you, Dr. Russo.
Thank you very much for inviting me.
Thank you.